Welcome back, everyone, to Part 143 of our masterclass on Advanced Physician Advisor Integration and Concurrent CDI Strategy. Today, we're stepping into the executive capstone phase, taking all those foundational coding rules and applying them straight to high-level hospital revenue cycle leadership. Now, right off the bat, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. All right, let's jump right into it. Before we dive into today's advanced strategies, let's quickly recap our last deep dive. In Part 142, we explored the high-risk clinical audit protocols for sepsis, cardiac, and surgical DRGs. You probably remember that for conditions like severe sepsis, you absolutely have to have explicit documentation linking that infection to localized organ dysfunction. Missing those critical clinical indicators, well, that's a fast track to massive revenue leakage and some serious compliance headaches. So, here's our executive syllabus for today. First up, an intro and recap, which we just knocked out. Then we'll cover the physician advisor role, move into concurrent CDI workflows, tackle physician engagement and defense, and finally, wrap up with a summary and next steps. Let's kick things off with Section 1, the physician advisor role. We really need to define what makes the physician advisor so incredibly indispensable in today's inpatient environment. Think of the physician advisor as the ultimate translator. On one side, you have the clinical realities of patient care, which are fast-paced, highly complex, and entirely focused on patient outcomes. But on the other side, you've got the incredibly strict, highly regulated financial necessity of revenue integrity and IPDRG grouping. The physician advisor is the strategic bridge between these two worlds, making sure the amazing care your clinical teams provide is actually reflected in the codes and metrics that keep the hospital running. And their C-suite impact is literally profound. Their core responsibilities include validating clinical documentation integrity and conducting critical level of care reviews, like the 2-midnight rule, to justify inpatient status and protect against major compliance audits. They also lead peer-to-peer appeals directly with payer medical directors. This doctor-to-doctor communication is a total game changer. It elevates the hospital's case mix index and drastically reduces medical necessity denials, all while championing a culture where providers see documentation as a natural extension of top-tier patient care. Moving right along to Section 2, concurrent CDI workflows. Now we'll look at the actual mechanics of the working DRG versus the final DRG. When a patient is admitted, a preliminary or working DRG is established. But here's the thing. As the patient's clinical progression unfolds, maybe they develop acute respiratory failure or their kidney function declines, this working DRG evolves in real time. This is totally different from the final DRG, which gets locked retrospectively at discharge to figure out the final payment. A solid concurrent CDI strategy ensures the working DRG captures every single nuance of the patient's severity of illness way before they ever leave the building. But a robust concurrent review protocol doesn't just magically happen. It relies on a few key steps. It starts with daily multidisciplinary rounds and actively monitoring EHR clinical triggers, like a sudden spike in creatinine. From there, it's about formulating real-time, evidence-based queries while the physician is still actively managing the case and getting their response to update the coding right then and there. This completely eliminates the nightmare of trying to chase down doctors weeks after the patient has gone home. And when you are formulating those queries, you need to focus on high-yield drivers. These are the conditions that often make the difference between a standard DRG and a higher-weighted one with a major complication or comorbidity. For instance, with acute respiratory failure, we need to clarify the underlying etiology. Is it hypoxic or hypercapnic? With sepsis, what's the exact organ dysfunction linked to the infection? For acute kidney injury, we need the specific stage based on eGFR or creatinine. For acute encephalopathy, we need to link it to metabolic or toxic causes. And for malnutrition, we need the exact severity defined by criteria like severe weight loss. Having a physician advisor drive these specific queries is absolutely crucial for protecting the true clinical picture. Okay, on to Section 3, physician engagement and defense. Here's the million-dollar question for any C-suite leader. How do you actually manage query-resistant and non-responsive providers without completely alienating your clinical teams? Let's be real. Doctors are swamped. So when they get a query asking for more specificity, it often feels like just another annoying administrative burden instead of a clinical necessity. The secret here is clinical coaching, not policing. Physician advisors lead this charge with data-driven physician engagement and targeted one-on-one feedback sessions. Instead of just firing off an email, they sit down and show the provider exactly how their documentation impacts their own severity and mortality profiles. We're talking service line-specific documentation tip sheets, integrating this stuff into resident and fellow onboarding modules, and yes, establishing clear escalation pathways for those unresponsive queries to make sure everything stays compliant. Speaking of compliance, we have to adhere strictly to standards from bodies like AHIMA and ACDIS. This means compliant queries must always be non-leading and evidence-based. For example, if a patient's hemoglobin is 6.2, you can't just ask, "Doctor, do you agree this is acute blood loss anemia?" That's a leading question and a huge red flag for an audit. Instead, you keep it open-ended. You say the patient's hemoglobin is 6.2 following surgery. Can you clarify if the anemia is acute, chronic, or due to another cause? You have to give the physician the clinical freedom to actually make the diagnosis. And to piggyback on that, every single query must cite specific clinical indicators straight from the patient's record. You can't just ask for a sepsis diagnosis out of nowhere. You have to point directly to the elevated lactate, the positive blood cultures, the tachycardia, or the altered mental status. It has to be perfectly auditable. The query is justified by the clinical evidence, not just because you want a higher-paying DRG. This evidence becomes your best weapon for peer-to-peer appeals mastery. When a commercial payer tries to deny or downgrade a claim, like trying to drop a complex sepsis case down to a simple infection, the physician advisor steps in. They synthesize all that clinical evidence, the lab trends, the vital signs, and leverage official ICD-10 coding guidelines to defend the DRG assignment and inpatient status. They have the clinical chops to speak doctor to doctor and completely shut down those unwarranted payer downgrades. All right, let's bring it all together in Section 4, Summary and Next Steps. To sum up this executive capstone, we've seen how physician advisors are the essential bridge between clinical care and IPDRG accuracy. We know that concurrent workflows are vital for evolving the working DRG in real time. We've highlighted how high-yield queries need to focus on specificity for things like sepsis, AKI, and malnutrition. We learned that data-driven coaching is the key to transforming query-resistant providers. And finally, that evidence-based peer-to-peer appeals are exactly how you protect the hospital's case mix index. This sets the stage perfectly for Part 144, where we will dive into complete denial lifecycle management and actually overturning payer DRG downgrades. So if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. I'll leave you with this thought to chew on. As a healthcare leader, are you truly prepared to master the denial lifecycle and defend your clinical data when the pressure is on? Think about it, and I'll see you in the next lesson.